are currently providing a provincial program for family caregivers, and we provide support through our telephone support line, one-to-one caregiver coaching. We do education and webinars wherever possible, and we also have a website that has a wide variety of resources for family caregivers to access. So I just want to make sure that everyone can hear me and the volume is good. If there's any feedback that you need to give, please let me know and I'll adjust accordingly. And if I recall correctly, I do have access to this PowerPoint, so that's great. So there's just a quick slide. I think I just talked a bit about this with regards to the Family Caregivers of British Columbia. Essentially, we're an organization that's dedicated to family caregivers from a more general perspective. So it's great that the Parkinson's Society has very disease-specific family caregiver supports. I think it's really important. We have such an amazing level of expertise within our own communities with family caregivers and those living with Parkinson's, and it's great that there's a place for us to have that support. And we often refer many family caregivers to the Parkinson's Society when we begin to understand where some of their challenges are. So it's great that we're able to help each other out here. I think you've probably already covered the webinar norms. That's just usually part of our presentation. And what we really hope that you'll get out today is that you'll have an increased understanding of what's involved in transitions to complex care or long-term care. The idea around maybe a bit more of the pragmatic sides of transitioning, so looking at how best to use some checklists, some strategies to decrease the stress on the person moving, as well as the family caregiver, and hopefully to maybe apply some of those strategies in your role as a caregiver. What I'd like to mention is that if we start going down this presentation and there's some questions that you have that are maybe more specific to having conversations around complex care or what the process is, say, for example, living in a community and going on a wait list for complex care, or how you determine that transition. We can certainly talk about that too. I would say this presentation is a bit more, well, quite frankly, it's a little bit dry sometimes. So if there's a specific example that we can pull from, or if you have an example, then I'm more than happy to use that or integrate that into the presentation. So we just talked a bit about what we're gonna connect with today, and I think what's important to note is that some people think that the transition to long-term care is sort of you get notice, you move, and then that's it. But in fact, there's quite a number of transitions that occur and quite a number of steps that take place. And I've put together this diagram here because in a way it's, the first step is often preparation. And that's often, for example, when you know that a move to complex care or a transition is coming up, it's around that preparation piece and knowing what some of those particular care needs are, gathering some information. I encourage people, regardless of whether you're looking at private complex care or if you're looking at our publicly funded system, it's always really good to view facilities in your area, because even though we may not feel like we always have a choice, we can list our preferred choice. And there is a big difference sometimes in terms of food, recreation opportunities, location. So where possible, I still encourage people to view facilities on their own. Some decision making, if that'll come into play in terms of, again, if you're looking at private or public, what happens when you actually receive the call, and typically it's 24 to 48 hours to move that person. What happens on admission day and what happens post-admission day. So as you can see, it's actually quite a numerous, there's lots of numerous steps in the actual transition piece. So I think the first acknowledgement piece is that a move to long, and I still use the word long-term care because it's something that I feel that most people can relate to, even though technically we use the word complex care, or that's what our health authorities use is complex care. Sometimes we hear residential care. Occasionally, I still hear people referring it to as an old folks home or nursing care, but I typically use long-term care or residential care. And really that, when people are transitioning to long-term care, it can be full of a lot of twists and turns and sort of feel like you're on a roller coaster ride, and which, some days you don't know where is up and where is down. And even though the preparation piece and the wait piece can be quite long, the actual physical move happens quite quickly. And so sometimes it's the anticipation that can feel longer and feel quite emotionally draining. There are some individuals that say once they actually get into, once they've done the transition, it's a bit of a relief because in a way, it's finally over. The one thing I also do want to mention is that there's something that we talk about at the Family Caregivers of British Columbia, and it is, home is best, but it's also, well, who's at home? And 97% of people over the age of 65 live in their own homes. So we're looking at a very small percentage of people that actually move into residential care. And so while the transition to residential care is a really important topic, it's also to recognize that it's often only suitable for those individuals who have very complex care needs, who need 24-hour nursing care, where the needs are too great for both our publicly funded system to support and, of course, family caregivers, whom we know do 75% of the work to keep the person they're caring for in their own home. So I just like to remind people of that piece. So one of the things that I encourage people to think about, and in general, I think this is a wonderful tools to use. And again, I'm just going to remind people that a lot of what I do as a gerontologist or working with families is really the practical side of caregiving. Although I'm a very compassionate and empathetic person, I often work with family caregivers to work with them to recognize the importance, for example, of good documentation, of how do we take all the information and expertise that we know as a family caregiver and the person who's receiving care, what they know about themselves, and how do we pass on that information and knowledge to the people working, say, in a residential care facility? Because at the end of the day, what I find, and what families tell me, is that the more that they're part of the care process, and the more that they can pass on their information, and the more that they can be specific about types of care, then the transition often goes a bit smoother. Now, we could have a whole other webinar on how to be your best advocate in long-term care, and how to work with staff in a residential care facility, and how to overcome some of the challenges. That's a whole other presentation. But one thing that's really important is starting this idea of a personalized care plan and life story. And the more that we can provide that information to individuals who are going to be doing care, we often find that, as I said, the transition is smoother. And so where that starts with, for example, it's just understanding what you're doing as a family caregiver, how best to document that. Now, I understand that's work, but my philosophy is that if something happened to you as a family caregiver, you'd want to have that information documented anyway, because without you, the person who you're caring for is likely not able to stay independent. Now, that's a little easier said than done, than having someone like myself looking in saying, well, it'd be great if you documented that. But it is also a very good preventative measure. So a personalized care plan really, kind of looks at what the person you're caring for can do on their own, how you're supporting them, if there's specific things that if there's specific ways that they need to be cared for, those are documented. And the life story really is just about who that person is. And I never use the word who that person was, because I think it's really important that we recognize that the person who's living with a disease, whether it's some form of dementia, whether it's Parkinson's, post-stroke, that they're still that person. It's just that the disease has impacted their abilities. And so getting a good historical sense of that person is such a nice way to honor those preferences, but also give staff a really good, deep understanding of the individual. The other thing really is having a journal, and you likely already have this as family caregivers. But anytime you can have a journal where you can document information, where you can make critical notes and keep it with you, we find that that's very, very helpful, especially through a transition. There's lots of information. You're going to be talking to a lot of different people, and honestly, who's who in the zoo can get complicated, especially if there's a hospital admission or hospital discharge prior to, say, long-term care. So that's just something that we also encourage family caregivers to look at, is if you aren't using a journal or a book to track information, to consider that. And of course, connecting with people who've been there and who've done that, that's also a really important component. And I suspect that within the family caregiving community at Parkinson's Society, that there is that ability to connect with others who have gone through it, or in your actual own community. From a very practical perspective, it's also really important to kind of make a list of what are some of the kind of the bills and mails that need to be redirected. Now, this would be for, say, non-spousal caregivers. So if you're an adult child caring for an aging parent, and your power of attorney, well, it's making sure that all those bills and mails get redirected, and that what needs to be paid and when it needs to be paid. Okay, so I've touched on the personalized care plan a bit. These are some of the kind of the key areas to look at. So biographical notes, what a daily schedule looks like, preferences around leisure activities, personal care preferences. We all have certain ways that we like to do our personal care. And so again, having that documentation is helpful. So one of the things that we talked about, through this decision-making piece is getting to know the different facilities. And I'll just use the Comox Valley here as a very quick example. We have 4 different long-term care facilities. We have 3 facilities that are publicly funded only. Of those 3 public facilities, we have 1 that is managed by a nonprofit, and then we have 1 private facility that is a mix of private and public beds. And so we also have, so the geographic range of those facilities are sort of 30 kilometers is the radius. But one of them is up a hill, and so if we're dealing with a spousal caregiver who is elderly and driving and snow's an issue, then that's a really important factor to consider, and bus routes don't go up that route. So that's why actually getting to know the different facilities and location and thinking practically of travel times to and from is really important. But the other thing about these different facilities, which is really interesting, is that each of them has their strengths and each of them has their the areas that they might recognize they might need some improvements with. So, for example, one of the facilities has a really strong recreation program, and for individuals who are socially isolated, who are really social, that's often a very big draw. One of the limitations is that the food is not particularly good because it's attached to the hospital, and so they use the same methods of feeding the hospital patients as they do residential care. They do have a dietitian, of course, but whereas another facility, which has a really strong recreation, really great food, and it's run by the nonprofit, is a fantastic, and it is the highest in demand facility, but it's the one that's also up a hill. There's no bus that goes to it, and so location-wise, it's really suitable for someone who can drive, who has very good mobility, who doesn't mind, being doing that type of transportation. So, because typically, the care ratios and the number of staff on board, those are all going to be inherently the same because of the standards in which Residential Care Act states. But the little differences, food, recreation, how how care staff are trained, if there's extra projects that facility is working on, are they active in the community to get grants, what type of volunteers do they have, that's actually a really, really, really important component. So getting to know the facilities is I think is really important as a family, and for the person who's moving in, of course. So in terms of the facility piece, we've talked a bit about this. Now, I've had to do generic slides because whether you're going into a private facility or public, there are some differences. But essentially, what's really important is to know what's most important to you as a family, the person receiving the care, and you as a family caregiver. And that's making your list of your needs and wants for care. I always think it's great to have your wish list, and that's kind of your ideal. And then the other thing that I encourage family caregivers to think about is, and the care recipient, is what can I live with? And so we all typically want the best. We want to have everything on that list of needs met. It's also really good to ask ourselves, okay, well, what can we live with? What's acceptable? We've talked a bit about location. Now, if you're, say, looking at a publicly funded residential care facilities, contacting the facility, you actually can't. I mean, you can contact the facility. Just started there. You can contact the facility and ask them, if you can come up and see it and indicate that you're thinking about transitioning to long-term care, or that you're on a wait list and you'd like to see the facilities. And they'll certainly encourage you to come in. They may not have a person that's going to take you around the building or around the different areas. Whereas if you're looking, say, for example, at private care as a transition, some people go into private care because they are in dire need and there's no publicly funded beds. They don't want to stay in a transition unit. So they decide to pay out of pocket until they can get rolled over into the public system. So in that case, then you have a private tour, and that's a little bit different. Okay. Oh, thanks, Miriam. Miriam just sent me a note that I'm doing great. There's also some really great checklists for assessing facilities. And Miriam, if you're interested, I can certainly send through one that I encourage family caregivers to use. Just send me a reminder, and I would happily do that. What I also recognize is that I'm probably, there's probably a lot of information right now. And if you need me to slow down, or if you want me to talk about one particular area a bit more, please let me know. I feel like it's like verbal diarrhea sometimes in some of these webinars. So one of the other important pieces that in also the preparation part, and in all likelihood, most of you already have all this done, but these are really good, handy documents to make sure that are current, that are up to date, that are handy for you right away. And Miriam, the other thing that I just wanted to touch base with is I should send you a link to the workbook that I have. It's called Get Your Elder Care Affairs in Order. If you remind me about that, I'll send you the link to that, because for some family caregivers, it might be a really good resource to have. Mm-hmm. It's a great way to kind of get that information in one place. So whenever I give presentations on planning, I always say to my audience, if you ignore everything that I say in a webinar, that's fine, but don't ignore this one. Make sure that you have your power of attorney, your healthcare representative, your advanced care directive, that you have all of your any extended health or Department of Veterans Affairs information, that you have your most recent notice of assessment, that you have that at your fingertips and done. Those are actually such important documents in the planning process, whether it's just receiving more care in your home or having to go into a long-term care facility or make that move. I think the important thing that I do want to stress is that, and again, if this is repetition, just let me know. But sometimes there's a misconception that when when the person we're caring for becomes too complex or their care needs become too high, that it's a very quick process to roll over into complex care and residential care. And I think it's really important to know that that's not always the case. So while home is best for most people living with Parkinson's or stroke or other chronic diseases, we know that a lot of the care is being done by family caregivers, that there's not always the support for family caregivers. It's really important to know as family caregivers that that transition can take anywhere from 3 to 6 months once it's determined that the person that is receiving care needs residential care. It's a bit of a process. So here on Vancouver Island, with Vancouver Island Health Authority, they have to be reassessed by their case manager. The case manager needs to say, okay, I'm going to put this forward to a panel of information, or sorry, a panel who is then going to determine and give the go-ahead that yes, this person who I'm caring for is going to be placed on the urgent care list or a priority care list. And then it's really waiting. And so if that person's in a transitional care unit, say, or if they're living in the community, then sometimes the priority and the urgency is different. So rough numbers here on Island Health. So for every 4 people who need residential care, for every 4 people that live in the community that need residential care, I'm sorry, let me back up. So if you had 4 people who needed residential care, the kind of the highest priority are for those people living in or who are in hospital or in a transitional unit. So of those 4, 3 from hospital would have priority access, 1 from the community. So that's just sort of kind of give you that ratio. Now that doesn't mean that we'll just place ourselves in the hospital and we'll get into residential care. That's not the solution there. But it's just important for people to know that when it comes to residential care, the push is still to free beds up from the hospital and transitional care units. And so if you're living in the community, it's really important to be kind of thinking about that process in terms of identifying when that transition is and not waiting too long. It's better to be reassessed and for them to say, no, you're not quite ready, than to hit a crisis and for them not to be able to make good decisions or be able at least to have time to explore. Okay, so do you really have? Yeah, that's a good point, Peggy. So we can put our preference down, and I find typically case managers or the individuals that are part of our care team, they do try and honor our process as much as possible. Now, whether you live in rural or whether you live in urban, sometimes there are some differences around that. What I will say is that I have had successful family caregivers who've had to go into one care facility and then have transferred to their care facility of choice. It might have taken 9 months, but that, is a possibility. I think it's also really important to know that what I like to say is it's not our system, it's our system that's broken. It's not the people who work in the system. And so having good relationships with your case manager and really being clear about why that facility is your first choice is really important. And so, for example, if you're a family caregiver, whether you're an adult child or a spouse, and you understand the importance for not only the care recipient, but for yourself, and you're able to document that in a very clear, systematic way, then I have found that case managers will honor that as much as possible. So I know I'm not really saying on a scale of 1 to 10, you have 80% chance of getting the referral, or of getting the facility of your choice. I'm not saying I couldn't predict that, but there are some measures that are really important to factor in when you're making that choice, and having a good sense of what the facilities offer and some of their differences are going to help you just determine which one might be a better fit. So I hope that answers your question, Peggy. So in terms of the transition piece, I know we just kind of touched on this part. So often, what happens is, and again, I'm not sure where, there's going to be a huge range of where people are at in terms of where the disease has progressed. But typically people that are thinking about transitioning to residential care, you get the sense that, okay, we're hanging in here in our home. Care is becoming quite high. You might be getting close to your maximum support, say through home and community care. You're a little concerned about your ability as a family caregiver to be able to manage your role. Maybe your health is changing a bit. You're kind of getting these red flags or these signs that you're not sure how much longer you're going to be able to continue providing care, or the person with the disease is going to be able to stay as independent as possible. So, typically when you hit that phase, that's the perfect time to have a reassessment done by a case manager. What's really important, and again, I'm so sorry that this is so practical and strategic. As family caregivers, it's just really important to document some of those key changes that you've noticed in the last month or last 3 months, so that when you have a reassessment, that you can be really clear with the case manager as to why you're asking for the reassessment and what concerns you have. And then they'll, reassess using the RIE. What I encourage family caregivers, again, is to be really honest about their abilities. And so sometimes we're so proud, and we really want to be able to keep the person living at home as long as possible. And I think it's important to know, again, people working in the healthcare system, they want that for us. But if we cloud, or if we make our situation look better than what it is, then we're not going to be able to access support and care in a timely manner, because they use that information on that RIE assessment, that home care assessment, as how the family caregiver is doing, how the care recipient's doing. So I just really encourage people to be really honest about their own abilities and limitations. So have that care assessment done. Let's say the case manager says, yes, you know what? I believe, based on the situation, that a move to residential care, that you're eligible for that. So at which point what happens, and again, there's some differences between health authorities to health authorities, but typically what happens is that they put that request in, and then the information goes to a panel. And that panel determines or approves the request for residential care. At which point, then it becomes more of a, when is it going to happen? Now, as I said, if you're in hospital or if you're in transitional care unit, typically the wait times are a little bit shorter. But still, if you're in a transitional care unit, it could be 2 to 3 months. And if anyone has had someone or knows someone who's in a transitional care unit, we know that it's not the best place. Neither is the hospital. It's not the best place for someone to be while they're waiting for care. So that transition tends to be a little bit quicker into care. I might argue at that point in time that's first available bed, and so the choice factor might be a little less. When you're in the community, perhaps it's typically a longer wait, but you might have or afford the ability to have a little more choice. And then once so then now we're here. So once the call actually comes in, it's usually a very quick turnaround time. So usually it's 24 to 48 hours. It just barely gives you enough time to get your ducks in a row. Usually you just figure out what time the arrival should be at, and then usually that's coordinated between either the case manager and the family caregiver. If you're in hospital, it might be by the transitional care unit liaison or the clinical nurse there. They might be doing that physical transition piece. how the person's going to be transported, what needs to come with them at that point in time. Okay, have I missed any questions? I don't think I have.
So we do have two questions, and I think both of them are very similar, and they came in through our Q&A.
Oh, here we go. Okay, I see them now. Okay, sorry, I had the wrong tab. How do you get a case? So Cheryl's question is, how do you get a case manager for the person that might need one? Oh, okay. And two, what is the process? Oh, okay. So these are questions that are definitely prior to thinking about residential care, but I'm happy to address them. So essentially what it involves is it involves contacting your local home and community care office. So it's going to your health authority website, or if you have a health unit that you can access, it's actually getting the intake number. And essentially it's making a phone call. Anyone can make a phone call. It can be the family physician, it can be a family caregiver, it can be a concerned neighbor, it can be the care recipient themselves. And what that process looks like is essentially you make a call to the intake. They may or may not be available at, thank you, Miriam, at that point in time. They're going to call you back and they're going to collect some information from you about why you're looking for an assessment. And so, as I had mentioned earlier, having a good sort of case as to why an assessment is required is really important. So I think it's even one more step back to say, why would you even want an assessment? And that is that you're noticing that the person you're caring for is, for example, having difficulty bathing, having difficulty with medication management, is having difficulty, getting dressed and doing those types of personal care. And you as a caregiver, for whatever reason, whether it's care needs are too high, you're working full time, you have your own health care conditions that or quite frankly, you don't want to do personal care, which is just fine, that you're not skilled to do personal care, that having someone be able to provide those types of supports, that's what our publicly funded system will do through home and community care, through home support. So that is when you would actually want to engage, to have what they call an in-home assessment, and that would involve a case manager who then comes out and does the assessment. Sometimes they send out an occupational therapist, sometimes it's an RN, it depends, and they become your case manager. They do the assessment. Now, when they finish the assessment, they will typically say, okay, here's what you're eligible for in terms of care, and they'll kind of give you a sense. And at which point then as a family, you decide, okay, are we going to use, do we want to use this? Is this enough? For sometimes your needs may not be personal care related. They might be more bigger picture. And again, that's a whole other webinar. So that's a bit about why you need a case manager. You start the process. The intake person is going to call you. You're going to give them the story as to why you feel an assessment is required. They'll then kind of determine, okay, yes, this sounds like a scenario that needs to be addressed, and they'll set up a date and a time to come in. And again, that varies. It depends on the urgency, but that can take anywhere from, in best case scenarios, 2 weeks to 3 months to get an assessment done. And then again, after that assessment's done, one thing I really encourage people to do is to write down the case manager's name and their phone number, to get a copy of any, to get a written copy of eligibility if they are eligible for services and what that is, to actually get that in writing. Sometimes I just had a conversation with a caregiver today who's a long distance, so it's a little bit harder. She said, I don't know who my mom's case manager is. My mom doesn't know. She was there for an assessment at the end of October. They said that she's eligible for morning medication. They haven't started yet. And so here she is trying to figure that out. Her mom's been in and out of hospital. And she has, she has congestive heart failure. So she needs her medications in the morning. And so that's, again, those are the reasons why we want to know who's in the zoo and write that information down. That's why you've got your journal. What's that person's role? And then it's like when you are feeling overwhelmed and it's like, oh, who was that person again? That at least that information's in one spot. Okay, coming back to the presentation. So when the call comes in, we talk, kind of talk a bit about this piece. I'm going to go through that slide. Okay, so the transition happens into a residential care. Typically one thing you can ask is if they have a package. Sometimes they have a package of information. Sometimes they won't. It really depends on the facility. But sometimes they have a neat little package that says, here's what you need. Usually, like most important, I would say, is, how much clothing can the person bring? What important belongings do they want? Assistive devices, making sure those are all labeled. Copies of any kind of legal or financial documents that were required. Usually medications are dealt with, but sometimes there's other requirements. Again, these advanced care directives. Now, usually staff and hopefully the physician prior will have done those advanced care directives or levels of interventions. Usually those are done. You usually can't move into a long-term care facility unless you have all of those pieces done ahead of time. And then some very practical things after the move. There's contracts, there's paperwork. You typically will meet with the administrator or the director of care. You'll have a meeting with a dietitian, being assigned a dining table, other residents. They'll review kind of programs and security features. Now, this is what I've learned through working with family caregivers who've done this transition, that I think it's really important that when someone moves into residential care, and the feedback that I've got is that you can request or you can ask, for example, to have for them to kind of do what's called a voiding assessment. So how that person is using the toilet and frequency and how independent they are. The second one usually is around sleeping, patterns, how that, if there's any issues about waking up in the night. I always like to really make sure that weight's monitored, blood pressure's monitored, and typically that should be done on a regular basis. And that's something that I do when I work with families privately and they have family in residential care and they don't live here, is every week I go in and ask any changes in weight, any changes in blood pressure. I do my overview of the person. I ask if any changes in sleep patterns, any changes in voiding. And that's actually a really important information as family caregivers to have. Because again, it's not the people in the system, it's the overarching system. That sometimes what happens in residential care is information might be tracked, but sometimes it's not always analyzed until something happens or there's a big change. And so monitoring along the way is one of the key ways that we can be strong voices for the person we're caring for and for ourselves as a family caregiver. Because I have also found there's a misconception sometimes that people feel when after they move is that, okay, well, all those care needs are being looked after. But in fact, the role of a family caregiver becomes extremely important when someone moves into complex care. Okay, so here's just a couple of few ideas for anytime we're engaging in transitions. Of course, engaging the person to the best of their abilities in setting up their new space and room. Where possible, bring your old environment into the new space. There's a lot of stress involved in relocation stress for the person being moved and for the family caregiver. There's lots of emotional transitions as well. If you have a support team, family, friends, it's always great to have them support through that transition and beyond where possible. And where possible, maintain established routines. So after the move, I'm just wondering, Let me just go through. Let me just take a look here. Right. I think so. After the move, I just think what's really important is that relocation, it can take someone upwards of 4 weeks to work through that new environment. There's these sort of immense feelings of feeling overwhelmed at times. Sometimes, but otherwise, sometimes people are ready for it. There's always an adjustment phase, and that is just readjusting to a new routine, a new people, and that can be with dementia. That can also be very challenging. And sometimes there's this initial acceptance, and that's not even just always for the care recipient, but for the person receiving care or doing the care. I think, what is really important, and let's just call a spade, when someone goes into residential care, we know that this is their last move. It's unusual for people to go from residential care back into their home. It does happen, but it's very rare. And that's a major life change. It's a real acknowledgement of where we're at in our life stage and life transition. I have this saying that one of the things that I try and work on as a human being is effortless discomfort. And it seems like the older I get, the more I'm realizing that these major life transitions, even for myself at 44, but also for individuals going through these major transitions, it's a lot of discomfort, a lot of uncertainty with our emotions. And so my mantra is sort of this effortless discomfort, that I'm just going to be uncomfortable. I'm going to experience discomfort, and it could last an hour, it could last a day or 3 days. To understand that acceptance is different for everyone, and we're all going to move through different acceptance levels. I always like to say, like, caregiving, don't go at it alone. It never ends well. When we're family caregivers and we try and do it all ourselves, honestly, in 90% of the cases, it never ends well. We're not designed as human beings to solely be able to care for one person. And it doesn't mean that that's easy for us to recognize. And there's lots of other reasons why it can be difficult for us to ask for help, and we won't get into that. And it's easy for me to say that on the outset because I'm not in your shoes. I usually just kind of go with the proof in the pudding a scenario that, especially with the transition to long-term care, it's a major transition, and anywhere you can receive help or ask for help, you will stay healthy as a caregiver, and the person you're caring for will also reap the benefits. I think, although it's important to acknowledge the difficulties, where possible, giving that person choice and motivation versus focusing more on what's not working is a good strategy. And so I often remind people that sometimes choice doesn't have to be where that person wants to, like, do they want to go to facility A or facility B? That might be too large of a choice for someone to make, but sometimes the choice is much more basic, but it's still a choice. And I see I've got 4 minutes left, so I'm going to stop talking momentarily. I was doing some reading on resistance to change, and it's often around the fact that we feel like we lose our ability to make choices, but sometimes just having a choice between whether you want an apple or an orange, I know that's ridiculously simple, but there are times where having that type of choice is very empowering, even though it seems like a small. And so that's one thing I certainly encourage as families, where possible, is to honor that choice in whatever degree that is, based on the person's capacity. So I also just want to encourage people that if they would like some additional support that they're not able to receive through the Parkinson's Society, that we have our caregiver support line. Our Education Resource Center has great information, but more on global aspects of family caregiving. and you're certainly welcome to peruse that area. And if you have any other follow-up questions, then you're more than welcome to email those to Miriam, and I'd be more than happy to answer them, and she can share them with the group. So I just want to thank you for your time and for listening and for your engagement and your questions.